All right, get ready to dive deep into fracture fixation.
The nuts and bolts of how to get those broken bones to mend?
And I mean that literally.
Yeah, we're going to be talking about screws and plates and all sorts of hardware.
It's key for any aspiring orthopedic surgeon, especially if you're gearing up for exams like the FRCS.
And we're going to be drawing on some awesome insights from Dr. Mok Ying Ren,
His notes and audio are a treasure trove of info on this topic.
really breaking down the biomechanics behind successful fixation.
Because it's not just about putting the pieces back together.
It's about setting the stage for bone to regenerate.
So, to kick things off, let's talk about something I always thought was pretty straightforward. Screws.
Oh, you'd think so, wouldn't you?
Yeah, but I've learned there's a whole world of complexity when it comes to choosing the right screw for the job.
Absolutely. Cortical screws, cancellous screws, half-threaded, locking screws. It's a lot.
So why so many options? Break it down for me. What are the key factors that drive those choices?
Well, first you've got to think about the bone itself. Cortical bone is dense and compact like the outer shell of a tree trunk. Cancellous bone, on the other hand, is more porous, kind of like the spongy inside.
So you wouldn't use the same screw for hardwood versus softwood. Makes sense.
Exactly. It's all about matching the screw to the bone's density and structure.
Okay, that's starting to click for me. So
Mm.
tell me more about these cancellous screws. What makes them different?
A cancellous screw will have larger threads and a smaller core diameter compared to a cortical screw.
So more surface area to grip that softer cancellous bone, I'm guessing.
You got it. That larger surface area helps distribute the load and minimize the risk of the screw pulling out.
Makes sense. But why is the neck of the screw so prone to breaking? I always figured the shaft would be the weak point.
It's all about stress concentration. Think of it like bending a paperclip back and forth at the same spot. Eventually, it'll snap, right?
Okay, I'm with you.
So the neck of the screw, where the diameter changes, acts like that bend in the paperclip. It concentrates the stress there, making it vulnerable to fatigue failure over time.
So it's not just about getting the screw in, but using it to actively draw those bone fragments together.
Exactly. Kind of like clamping those pieces together to help them heal.
And what's the deal with washers? I've seen them used, but never really understood why.
Washers are there to distribute the load from the screw head, preventing it from digging into the bone and compromising the fixation.
I see. So it's about protecting the bone and making sure everything stays nice and stable.
Exactly. Now, speaking of screws, have you ever worked with reverse cutting screws?
I've heard of them, but not sure when you'd use them over regular ones.
They're great when you anticipate needing to remove the screw later, like in certain pediatric cases. The threads are designed to back out more easily.
Ah, that's clever. What about bioabsorbable screws? I find those super interesting.
They're amazing, aren't they?
Yeah, the fact that the body just breaks them down over time.
They're ideal for kids, where you don't want permanent hardware sticking around as they grow.
Makes a lot of sense. So we've covered the fascinating world of screws. What about plates? It seems like they provide more stability across a larger area of the bone.
That's exactly their purpose. Plates are your go-to when you need to bridge gaps, support those comminuted fractures where you've got multiple pieces, or control more complex forces.
I can imagine there are tons of different types of plates too, right?
Oh, absolutely. Neutralization plates, compression plates, bridging plates, buttress plates, each designed for a specific purpose.
So it's not just slapping on any old plate. You need to understand the biomechanics of each type and how they'll interact with the fracture.
Precisely. And then there's the art of shaping the plate to perfectly match the bone's contours. It's like sculpting almost.
I'll bet that takes a lot of practice to get right.
Yeah.
One type of plate I've always found particularly intriguing is the tension band plate. What's the deal with those?
Those are clever. They essentially turn a pulling force into a squeezing force.
Wait, how does that even work?
Imagine a bone being pulled apart at the fracture site. A tension band plate placed on the tension side actually uses that pulling force to create compression on the opposite side.
So it's like harnessing the body's own forces to help stabilize the fracture.
Exactly. But it's crucial to have a solid, intact cortex on that compression side.
Otherwise, you'd just be crushing the bone instead of supporting it.
You got it. It's a nuanced technique, but incredibly effective when applied correctly.
Now, what about pre-bending a plate? I've heard surgeons talk about that. Why is that important?
Pre-bending the plate to match the bone's natural curve ensures those forces are distributed evenly along its length. Think of it like an arch bridge. Its curved shape helps it withstand weight more effectively.
Okay, I can visualize that. And does the concept of working length apply to plates too? We talked about that
Yeah,
with
yeah.
screws, how it affects their rigidity.
Absolutely. The working length of a plate, the distance between the two screws closest to the fracture, directly affects its stiffness. A shorter working length means a stiffer construct, which might be good in some cases, but not others.
So, just like with screws, it's about finding that sweet spot between providing stability and allowing for just enough movement for the bone to heal properly.
Precisely. And don't forget about the near, far, far principle for screw placement.
Right, that helps maximize stability and minimize the risk of screws backing out.
Exactly. And these principles become even more important when you're dealing with tricky situations like commendud fractures, where you have multiple bone fragments to contend with.
So all this to say, plate fixation is a lot more nuanced than just slapping on a piece of metal.
You're telling me. Understanding these biomechanical principles is essential for making informed decisions that lead to better outcomes for our patients.
Okay, so we've covered the basics of screws and plates. Now let's move on to a challenge that often pops up on those FRCS exams: femoral neck fractures.
Oh, yes, those can be tricky.
And I know the go-to implant for these is often the dynamic hip screw or DHS. What's the thinking behind that?
The DHS is a great system because it provides stability while also allowing for controlled sliding as the bone heals.
So it's kind of like a dynamic internal splint.
Exactly. And a big concern with DHS is screw cutout, where the screw basically slices through the femoral head.
Yikes, that sounds bad. What causes that to happen?
It's often a combination of factors. You have patient-related factors like bone density. Weak bone, as you see in osteoporosis, is much more prone to cut out.
It's like trying to anchor something into soft, crumbly wood. It just doesn't hold well.
A perfect analogy. Then there's surgical technique, things like tip apex distance or TAD, and the angle of the screw trajectory.
Right, I've heard about TAD. So if the screw tip is too close to the top of the femoral head, that puts it in weaker bone, making cutout more likely.
Exactly. And choosing the right size barrel for the DHS is crucial too. A short barrel reduces the system's leverage, making it more susceptible to failure.
So it's like a multivariable equation where you're trying to find the optimal solution based on the patient, the fracture, and the implant.
Precisely. It all comes down to clinical judgment.
Okay, onto the lower leg intramedullary nails. What's the basic idea behind those?
Intramedullary nails, or IM nails, work by supporting the bone from within the medullary canal.
So unlike screws and plates that act from the outside, IM nails are all about internal support.
Exactly. It's like reinforcing a building from the inside out.
But there's a variety of IM nails out there. What are the key factors driving those design choices?
One big one is rigidity. A more rigid nail offers greater stability, but sometimes you need a little more flexibility to allow for that micromotion that stimulates bone healing.
So that balance between stability and movement comes up again.
Yeah.
How do you know how rigid a nail you need for a given fracture?
That's where material properties come in. For example, stainless steel is inherently more rigid than titanium.
Wait, the type of metal actually makes a difference in how much the nail bends?
Absolutely. And then there's working length, the part of the nail not supported by bone. The longer the working length, the less rigid the nail.
I'm picturing a diving board. The further you go out, the more it bends under your weight.
Exactly. And that's where reaming comes in. Enlarging the medullary canal to fit the nail essentially shortens its working length and increases its rigidity.
So you're maximizing that bone and nail contact. But doesn't reaming also disrupt the blood supply within the bone? Does that affect healing?
Reaming does initially disrupt blood flow. However, the body compensates by increasing blood flow from the periosteum, that outer membrane surrounding the bone.
So it's like a detour. The blood finds a new route to nourish the bone.
Exactly. Studies have shown that reamed bones revascularize faster, which means faster healing.
Okay, so reaming, disrupt, and then boost. What about those concerns about heat generation during reaming? I know that can damage bone.
Avoiding tourniquet use is key to minimizing that risk. And for prophylactic nailing, creating a ventilation hole helps release pressure and reduce the risk of fat embolism.
So we're mitigating risks wherever we can.
Okay, on to the nails themselves. Why are hollow nails generally preferred over solid ones? Wouldn't a solid rod be stronger? You'd think so, but for the same outer diameter, hollow nails are much lighter, which means more comfort for the patient.
Okay, so less burden for the patient to carry around. But aren't they weaker?
Not as much as you'd think. And that hollow center lets us use guide wires during insertion, improving accuracy and safety.
So it's a trade-off, a bit less strength for a lot more practicality. I've also seen circular and cloverleaf nail designs. Does shape matter?
Definitely. Closed section nails, like the circular ones, offer better torsional stability, and cloverleaf nails have a unique spring mechanism to enhance stability within the bone.
I'm seeing a trend here matching the implant to the specific forces the bone will experience.
You're catching on. And the way you insert the nail matters too. Using a curved nail that follows the bone's natural curvature is essential.
But wouldn't a stray nail be easier to put in?
Imagine trying to force a straight rod into a curved tube. You'd get a lot of outward pressure, potentially damaging the tube. The same thing happens when you try to put a straight nail into a curved bone. You risk complications.
Got it. A curved nail just makes sense, both for the insertion and the long-term stability.
Exactly. Now, what about locking bolts? They seem to be all the rage with IM nails these days.
They're like those extra reinforcements to prevent the nail from bending or twisting, right?
Precisely. Unlike regular screws that rely on pull-out strength, locking bolts are designed to resist bending and twisting. They have a wider core and smaller outer threads, making them incredibly strong in those specific directions.
So they essentially lock into the nail, creating a super rigid construct.
You got it. Enhanced stability, but there are some trade-offs.
I was just thinking, aren't those holes in the nail for the locking bolts potential weak points?
That's a great point. Those holes can act as stress risers, weakening the nail. So if a fracture is near an empty screw hole, the nail might break at that spot.
Like the saying, a chain is only as strong as its weakest link.
Precisely. And the size of the locking bolt matters too. Larger bolts offer more stability but create bigger holes, potentially weakening the nail further. It's all about finding the right balance.
Okay, so locking bolts, a powerful tool but with some nuances to consider. What about their impact on bone healing itself?
That's another important factor. Too much stability can hinder bone healing. Using a ton of locking bolts can make the construct so rigid that it prevents the micromotion needed for optimal bone healing.
Right, like putting a cast on too tight, it immobilizes the fracture, but might slow down healing.
Exactly. Finding that sweet spot is key. Enough stability to support the bone, but not so much that it hinders the natural healing process.
Wow, so much to consider when it comes to fracture fixation.
Yeah.
Any other essential tools we should cover before we wrap up this part of the deep dive?
Let's talk K-wires and external fixation. They each have unique roles to play.
Key wires and external fixation, next on the agenda.
All right, so picking up where we left off, we've covered a bunch of different implants and techniques for fixing fractures, but let's take a step back and really dig into the why behind those choices.
Yeah, it's one thing to know the names of all the gadgets, but it's another thing entirely to understand how they actually work with the bone and all the forces involved.
Yeah, exactly. And that's where biomechanics comes in. Have you ever heard the terms load sharing and load bearing? They sound kind of similar, but there's a key difference.
I have heard them, but to be honest, I always get them mixed up.
Think of it like this. In load sharing, the implant and the bone are basically sharing the responsibility of bearing weight.
Sharing the load makes sense.
Yeah, you see this in those nice stable fractures where the bone fragments are lining up well. The implant is like a temporary helper, allowing the bone to gradually take on more and more of the load as it heals.
So it's like a crutch helping the bone along until it can stand on its own 2 feet again.
Exactly. Now, with load bearing, the implant is doing the heavy lifting because the bone itself just can't handle it.
Okay, so that makes sense. You'd see that in more complex situations.
Yeah, things like comminuted fractures where there are multiple pieces or if there's bone loss. The implant becomes the main support structure, kind of like a steel beam holding up a bridge.
Got it. So you choose your approach, load sharing versus load bearing, based on the fracture and how stable it is.
Exactly. And that's why understanding these concepts is so important. It helps you make the bare decision for the patient, like choosing an implant that allows for a bit of movement in a load-sharing situation.
Because a little bit of movement actually stimulates bone healing, right?
That's the idea. You don't want to lock everything down too tight, especially in those stable fractures where the bone can handle a bit of stress. But when you need that rock-solid stability, load-bearing is the way to go.
It's like Goldilocks and the Three Bears. Not too stiff, not too loose, but just right.
I like that analogy. Now, let's talk about age, because it definitely plays a role in how we approach fracture fixation.
Kids versus adults, I'm guessing.
Exactly. Kids' bones are still growing, and they have this incredible capacity for healing. They often heal faster and can tolerate less rigid fixation.
So sometimes less is more when it comes to kids.
Often, yes. But we always got to be mindful of those growth plates. Those are the areas of actively growing cartilage near the ends of long bones. Damage to a growth plate can really mess with normal growth. So we try to avoid implants that cross those areas whenever possible.
Makes sense. You wouldn't want to stunt their growth. What about older patients, folks with osteoporosis, for example?
That's a whole other set of challenges. Osteoporosis weakens the bones, making them more likely to break, and also more prone to complications like screw cutout.
Right, because the bone is just not as strong to begin with.
Exactly. So we might need to use bigger screws, plates, or even bone cement to reinforce the fixation.
So it's like compensating for that weaker bone by providing extra support.
Exactly. And of course, we also talk to our patients about fall prevention strategies and ways to improve their bone health.
That's a holistic approach, looking at the big picture, not just the fracture in isolation.
Exactly. Now, for a topic no one likes to talk about but is super important, complications.
Right, because unfortunately, things don't always go as planned.
Exactly. So let's talk about some of the common things that can go wrong. Infection is a big one.
Anytime you break the skin, there's that risk of bacteria getting in and causing trouble, right?
That's the issue. So sterile technique is absolutely paramount, and we also use antibiotics to help prevent infection.
It's like building a fortress around that fracture site to keep those microbes out.
I like that analogy. Now, besides infection, you can also have problems with the healing process itself.
Like the bone just not knitting back together properly.
Exactly. That's called delayed union or non-union. And there can be a number of reasons for that. Poor blood supply to the area, too much motion at the fracture site, smoking certain medications, underlying health conditions.
So it's like a puzzle trying to figure out what's going wrong and how to get things back on track.
And sometimes, despite our best efforts, a fracture just won't heal the way we want it to.
It must be frustrating for both the patient and the surgeon.
It definitely is. Sometimes you need additional surgeries or other interventions to get things moving in the right direction.
So it's not always a quick fix.
Nope. And then there's malunion, where the bone heals but in a bad position.
So it's crooked or twisted or something like that.
Exactly. And depending on the bone and the location, that can cause problems with function and even appearance.
It's like a building that's been put back together slightly off kilter. It might still stand, but it's not going to be as strong or look as good.
A perfect analogy. And of course, you can also have issues with the implants themselves.
Like they break or loosen or move around.
Yeah, all of those are possible. Remember those stress risers we talked about? They can weaken implants over time, making them more prone to breakage. And if an implant loosens, it's not going to provide adequate stability. Sometimes we even have to go back in and remove an implant if it's causing pain or problems.
So it's not just a one-and-done procedure. There's a lot of monitoring and follow-up involved.
Absolutely. And speaking of challenges, let's talk about open fractures.
Those sound more serious.
They are. An open fracture is when the broken bone actually punctures the skin, creating an open wound.
So now I've got the fracture itself plus the added risk of infection.
Exactly. So with open fractures, infection control is the top priority. We have to meticulously clean out the wound, removing any debris or dead tissue to prevent bacteria from setting up shop.
So it's like thoroughly cleaning a wound before you put on a bandage.
Exactly. And the timing of surgery can be tricky too. Sometimes we use external fixation first to stabilize the fracture and allow those soft tissues to heal.
So it's like a staged approach, control the damage, then fix the bone.
Precisely. Now, switching gears a bit, let's talk about biocompatibility.
Biocompatibility, what is that?
It refers to how well a material interacts with the body's tissues. Ideally, we want implants that are inert, meaning they don't trigger any nasty reactions.
So they're like welcome guest in the body, not causing any trouble.
That's a great way to put it. And luckily, most implants are made from materials that are well tolerated, like stainless steel, titanium, or cobalt chrome alloys.
But even with those, I'm guessing there's still a chance of a reaction.
Unfortunately, yes. Some people have metal sensitivities or even allergies, and sometimes you can get a foreign body reaction where the body basically tries to wall off the implant, which can cause inflammation and pain.
So it's about being aware of those possibilities and choosing implants carefully.
Especially if someone has a known history of metal sensitivities. Now, for something exciting, let's talk about biologics.
Biologics, like in fracture healing, I've heard that's a hot topic these days.
It is. It's all about harnessing the body's natural healing power to give that bone a boost.
I'm intrigued. What kinds of things are we talking about here?
Well, bone grafts are a classic example. They provide a scaffold for new bone to grow on. And then you have growth factors, these signaling molecules that attract the cells involved in bone repair.
So you're basically sending in reinforcements to help with the healing process.
Exactly. And then there's the whole world of stem cells.
Stem cells, those are the supercells that can turn into all sorts of different cell types, right?
They are. And we can use them to generate new bone tissue, bridging gaps and speeding up healing.
Wow, so it's like tapping into the body's own repair kit and amplifying it.
Exactly. And this field of biologic augmentation is really taking off with new discoveries and techniques coming out all the time.
Super exciting stuff. Okay, now let's shift gears a bit and talk about something that often trips people up, especially on exams. Fracture classification.
Oh yeah, those classifications can be a real headache.
There are so many different systems and acronyms, it's hard to keep them all straight.
I know what you mean. But understanding those systems is crucial for communication, making decisions about treatment, and predicting how well a fracture is likely to heal.
So it's the language of fractures. We have to speak it fluently.
Exactly. So let's break down some of the key things that go into classifying a fracture. First, we need to know the location. Which bone is broken, and where within that bone is the fracture? Is it the middle, the end, near a joint?
Location, 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 right.
Precisely. Then there's the pattern of the fracture. Is it a simple transverse fracture, a spiral fracture, a comminuted fracture with multiple pieces?
So the pattern tells you something about the forces involved and how stable or unstable the fracture is.
Exactly. Then you have displacement. Are the bone fragments still lined up, or are they shifted out of place?
Because that can affect stability and make things more complicated.
Exactly. And we also need to know if the articular surface is involved. That's the smooth cartilage that covers the ends of bones in a joint.
So an intra-articular fracture, meaning it goes into the joint, is a bigger deal.
It is. Those can be more challenging to manage and increase the risk of long-term problems like arthritis.
So it's like gathering all the intel on that fracture, its location, its personality, its potential for trouble.
Great way to put it. And once you have that information, you can use it to communicate effectively with other doctors, make treatment decisions, and even predict how well the fracture is likely to heal.
Okay, so it's not just about memorizing a bunch of terms. It's about using those terms to make sense of the fracture and guide our actions.
Exactly. Now, fracture fixation is just one part of the story.
Right, what happens afterwards is just as important.
Absolutely. Rehabilitation is key to getting patients back to their normal lives.
So it's not just about fixing the bone, it's about getting the muscles moving. Again, regaining range of motion, building strength.
Exactly. And rehab needs to be tailored to the specific injury, the type of fixation, and the patient's individual needs and goals.
So someone with a simple wrist fracture will have a different rehab plan than someone with a complex leg fracture that requires surgery.
Exactly. We often encourage early mobilization to prevent stiffness and promote blood flow, but we always have to balance that with protecting the healing bone.
The delicate dance, pushing the limits without pushing too far.
You got it. And physical therapists are essential for guiding patients through this process. They provide expert advice exercises, modalities like ultrasound, and a ton of encouragement.
It's a team effort. The surgeon, the therapist, and the patient all working together.
Absolutely. And remember, rehab isn't just about the physical stuff. It's also about addressing the mental and emotional impact of the injury.
Right, because injuries can really take a toll on people's lives, their work, their hobbies, their sense of well-being.
Exactly. So we need to support our patients on all levels, not just focus on the physical healing.
It's about treating the whole person, not just the broken bone.
Well said. Now, let's touch on a trend that's been gaining a lot of momentum. Minimally invasive techniques.
Oh yeah, minimally invasive surgery. I heard it can mean less pain, faster recovery, smaller scars. Is it all it's cracked up to be?
It definitely has its advantages. The goal is to do the same things we do with open surgery, but through smaller incisions with less disruption to the surrounding tissues.
So instead of one big cut, you might use a few small punctures and special instruments.
Exactly. And that can lead to all sorts of benefits like less pain, smaller scars, quicker recovery, and potentially even a lower risk of infection.
It sounds like a win-win for both the patient and the surgeon.
It often is, but not all fractures are suitable for minimally invasive approaches. It really depends on the complexity, the location, and the surgeon's experience.
So it's another tool in the toolbox, not a replacement for everything.
Precisely. And as technology keeps advancing, we can expect to see even more innovative, minimally invasive techniques coming out.
Very cool. Any other essential tidbits you want to cover before we move on? I feel like we've covered so much ground already.
We have, but I think it's worth reiterating one key point.
That's that.
The goal of fracture fixation is not just to stick those bones back together. It's about creating an environment where the bone can heal optimally. and the patient can regain their function.
Right. It's about restoring their quality of life, not just putting the pieces back in place.
Exactly. And with that in mind, let's talk about how all this knowledge translates into exam success, especially for those of you prepping for the FRCS.
All right, so we've delved deep into fracture fixation principles, but let's shift gears a bit and talk about how to nail those FRCS exams.
It's one thing to understand the concepts, but another to really articulate them under pressure.
Exactly. So less textbook, more exam strategy.
Mm.
What are some common traps candidates fall into?
One big one is getting lost in the weeds, memorizing tons of details without really grasping the underlying principles.
Right, because examiners are looking for problem solvers, not just people who can regurgitate facts.
Precisely. They want to see that you can apply your knowledge to real-life scenarios, not just parrot back what you've read.
Makes sense. So how do you avoid that trap? What's the key to demonstrating that deeper understanding?
Focus on the why. Don't just state what you do, explain why you'd choose that approach.
So, for example, if you're asked about managing a femoral shaft fracture,
Don't just say, I'd use an IM nail. Explain why that's the best choice for that particular fracture, taking into account the pattern, the displacement, any patient-specific factors, and all those biomechanical principles we've discussed.
so it's about showing your thought process, connecting those dots between the theory and the practical application.
Exactly. And don't be afraid to think out loud a bit during the exam. Let the examiner see how you weigh different options and arrive at a decision.
So it's okay to say something like, okay, based on these factors, I'm leaning toward this approach because...
Exactly. That shows you're thinking critically and not just spitting out rote answers.
Got it. Another area I know a lot of people struggle with is image interpretation.
Oh, yeah. X-rays, CT scans, those can be tricky.
It's like learning a whole new visual language.
It is. But the more you look, the more you start to see those patterns and recognize those subtle clues that tell you what's going on.
So practice, practice, practice.
Exactly. Spend time really looking at different types of fractures, assessing displacement, learning to spot those red flags.
And don't forget to connect those images back to the clinical picture. The patient's symptoms and exam findings should always guide your interpretation.
Absolutely. It's all about putting the pieces together to form a complete picture.
Okay, what about those tricky orthopedic eponyms? I know they love to throw those at us on exams.
Those eponyms are like a rite of passage. Make sure you know the classics, Colles fracture, Monteggia fracture, all the big names.
And not just the names, but their key features and how they're typically managed.
Exactly. Now let's talk about the viva voce, that oral exam component that can strike fear into the hearts of even the most prepared candidates.
The Viva, yeah, I'm already getting nervous just thinking about it.
I know it can be intimidating, but remember, the examiners are not trying to trick you. They want to see what you know, how you think, how you communicate.
Easier said than done when you're in the hot seat with the spotlight on you.
True, but a few things can help. First, breathe. Seriously, take a moment to collect yourself before you answer. Second, try to view it as a conversation, not an interrogation.
So engage with the examiners, show them your thinking, not just reciting from memory.
Exactly. Listen carefully to the questions, take your time, and articulate your answers clearly. And if you don't understand something, don't be afraid to ask for clarification.
That makes a lot of sense. It's better to ask than to give an answer based on a misunderstanding.
Absolutely. And remember, they might ask you to identify instruments or implants or describe common surgical techniques. Be prepared to walk them through your thought process, your surgical plan, your post-operative care. Show them you're thinking holistically about the patient's journey.
So it's about showcasing your clinical judgment, your ability to put all the pieces together.
Exactly. Confidence is key, and that comes from preparation. Know your stuff, practice your answers, and believe in yourself. Enthusiasm goes a long way, too. Let them see your passion for orthopedics.
Great advice. It's not just about what you know, but how you present yourself.
Exactly. And remember, the FRCS is tough, but it's definitely doable.
With hard work and the right preparation, you can absolutely conquer it.
And don't forget, Dr. Mok Ying Ren's notes and audio are an invaluable resource. They're clear, concise, and packed with insights.
Yes, his website and Instagram are great resources, too. We'll be sure to include links to those in the show notes.
Fantastic. To all those future orthopedic surgeons out there, best of luck on your FRCS journey.
You've got this. Just remember, it's not about memorizing facts. It's about understanding principles and applying them to real-world situations.
Practice, practice, practice. The more you expose yourself to different cases and scenarios, the more confident you'll become.
And on that note, we'll wrap up this deep dive into fracture fixation. We hope you found it informative and, dare I say, maybe even a little bit fun.
Until next time, keep exploring the fascinating world of medicine and never stop learning.
Thanks for joining us.